Well, we still have quite a lot of time for discussion. During today's session, we have all the top experts in the field of lungs and bronchi, including Professor Fan Nguyen, one of the leading professors regarding interventional endoscopy. We have Professor Hashimoto from Japan and Dr. Khan from Bach Mai Hospital. Besides that, when speaking about bronchoscopy in Vietnam, we cannot fail to mention Professor Tran Van Nock. Professor Nock is also one of the pioneers in the field of endoscopy. I remember when I was still at Cho Ray, back when the endoscopic system was extremely rudimentary, Professor Nock was the one who performed endoscopy and interventions, including biopsies. I remember in the past, needle biopsies through bronchoscopy. And under the guidance of those so-called X-ray screens, where in the past the radiation was so high that you could barely walk straight when you came out. Perhaps I should invite the chairpersons and speakers to come up to the podium so we can have an easier discussion. I invite Professor Fan Nguyen, Professor Hashimoto, and Dr. Khan. Yes, I invite the professors as well as colleagues to ask questions and perhaps offer comments. Please go ahead, professors and colleagues. Yes, I invite the secretariat to please bring microphones. Also, there are many colleagues here who might be new, so they may not know each other. Therefore, I ask professors and colleagues to please introduce yourselves, including your name and workplace, and if possible, your specialty. Please go ahead.
Yes, hello, respected members of the chair panel, respected speakers. I would like to introduce myself. I am Dr. Duck from Bach Mai Hospital. My specialty is respiratory medicine, and I also do interventional bronchoscopy, just like Dr. Hashimoto and Mr. Fan Nguyen. I would like to ask a few questions and raise some points for everyone to discuss regarding today's topic. First is the issue concerning approaches to pulmonary nodules. Currently, we see that there may still be few techniques in Vietnam, but globally, for example in Australia or Japan, they have been performing these techniques for quite a while and have a relatively complete set of approaches. For instance, using EBIS, robotics, or even CT guidance can be used to reach them. So I would like to ask, on a global scale, and regarding the direction of research and development, are there new approaches that allow us not just to diagnose, but to treat immediately? Agreed, these are cases that are early, such as adenocarcinoma in situ, or early stages as Dr. Khan just shared, where the lesion is a solitary pulmonary nodule of only 1 to 2 centimeters. When we reach it using modern endoscopic techniques, robotic assistance, or CT-guided ultrasound, are there techniques applied that can treat it immediately without the patient needing endoscopic surgery, perhaps through interventional techniques? Thank you very much. Is that all? Mr. Duke's question is to either diagnose first or skip diagnosis and proceed straight to treatment, meaning we diagnose and treat immediately using those techniques without having to put the patient through surgery.
No surgery, just treatment. Yes, 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 yes. Regarding pulmonary nodules, there are likely some techniques being researched, such as using ablation or others, and there have been some reports on that. Meaning we are currently participating in that research, but globally, there are many such reports. And in fact, for cancer, when treating, evidence is key, but treatment without high-level evidence brings pressure. Radiation and surgery are very effective, so other interventions are less likely to be adopted in traditional treatments and are rarely used. Without evidence, in the future, personally, I'm not sure if surgery will be popular, or if it will be the main approach. Radiation is highly effective. Okay. Regarding treating cancer without surgery, about those. In China and the UK, with Dr. PSA, Dr. Saw uses RFA, radio frequency, and there are papers on microwave in the US. But in the US, some hospitals had bleeding issues, and later they did very few cases. Whereas in China, there are many cases, about 200, using RFA. For this cryoablation, I don't know yet, it might not be cold enough to treat the cancer, so now people are using RFA a lot. Yes. Oh, and you asked about the GG, right? Yes. Well, I think there are two main issues with GG. Size under 30 millimeters without a solid component, that is important. When it is larger than 30, it might start spreading elsewhere. And the second issue is the 5 millimeters solid component. If we see a 5 millimeters solid part, then we worry it will spread. Perhaps here, just like with a few cases, we don't biopsy, right? We see it start to solidify or it's over 30 millimeters, maybe we can operate without needing a biopsy. In China, they do that quite a lot. Perhaps in Japan they do it as well. Yes. Oh, seeing a grade 3 to 4 on CT, just by looking at the CT, it's probably 99% cancer, for example. In that case, if you ask for a direct biopsy, you can try, but if the biopsy fails, we do a biopsy and take another one, and if it's still small, we just proceed directly to surgery. Since the CT scan already shows a 99% chance it's a surgical cushion, in such cases, we often don't need a biopsy, as it risks spreading to the pleura. Instead, we just send it to the surgeons to discuss. And if the conclusion is to proceed with surgery, the issue is whether it's near the pleura or not, rather than just looking at it. For example, if it's small, but centrally located in the lung, surgery will be difficult and require extensive resection. However, if it's just on the outside near the pleura, it may invade the pleura when it progresses, but it is less risky than central lesions. These are the factors. Therefore, when observing such a finding, you should consult with the surgeon before ordering a biopsy. Yes, I would like to invite my colleagues and teachers, and I also invite Associate Professor Fuang. Yes, first of all, I would like to thank the speakers for their reports. And I have a question for Dr. Phan Nguyen. I know Dr. Phan Nguyen is from Australia and has extensive experience in interventional techniques, especially treatment techniques. As just discussed with Dr. Duck, Dr. Phan Nguyen has also performed many cases of placing valves to treat COPD. Could you let us know, because actually, in Vietnam, some centers have approached this, but we face many barriers, namely cost, and secondly, the discomfort it causes patients due to a foreign body in the lung. And thirdly, the patient indications are not very common. Not many patients are indicated for it. So, could Professor Phan Nguyen share with us, considering the approach of placing these valves, what are the advantages in cases where it could be a direction for our intervention? Oh, the second question I want to ask Dr. Masao is, at Bach Mai, we have many patients with lesions in the large airways. These could be lesions in the trachea and the main bronchi. The decision is, as Professor Masao said, the guidelines are not clear, and it entirely depends on the doctor's decisions. It is difficult, in practice, with tumor lesions or strictures that are too close to the larynx, which is very challenging, or if the lesion is too long, then surgery cannot be performed. Next are the lesions located in the main bronchus and very close to the branching points of the lobar bronchi. Right. So, does Dr. Masao have any insights? Because when doctors at Bach Mai make decisions, it is very difficult, and there are many cases where, when trying to place a stent, it pops out or slips down. Then, when placing a stent in the main bronchus, it might not go into the right position, causing complications, and we have to remove it. I wonder if Professor Masao has any experience to share. That is all. Yes, well, VMA and COPD, there are a few terms I don't know in Vietnamese. The important thing is to choose the right patient, so first, we should take a CT scan, and that CT scan tells us where the emphysema is, which is called quantitative CT in English, and the software does that calculation for us. The second important thing is that the air must not flow from the upper lung to the lower lung, or from the lower lung to the upper lung. That is crucial. First, when choosing patients, the FEV1 needs to be, I don't know the Vietnamese term, it has to be over 15%, the gas transfer over 20%, and for the lungs, when doing the body box test, the residual volume needs to be over 175%, that's what we need to select. The CT scan is important because it shows us where the emphysema is, and we must check the fissures to know, because they allow air and phlegm out, but nothing in. If air travels between the upper and lower lungs, and we place a valve, it will never collapse. So those two issues are critical. If you want, I have a few articles that I can show you if you want. Yes. As for the issue of stents, my experience with placing stents, well, for me, it is a major issue. Yes, in my experience, if, for example, the main bronchus is narrowed and also long, and if the main bronchus is narrowed and I'm afraid the stent will move, I try to place a Y stent, but on the other side, or the opposite main bronchus, I cut it very short so it can be stabilized a bit. Or if the trachea is loose, like the main bronchus is quite long, then a Y stent for the second carina, and cutting the junction, the short part can also work. Yes, but currently, when it's malignant, especially when it's malignant, I place a stent. When it's benign, I place a metal one, but now there are limitations, so I try to place silicone ones and try to be careful. And if it's the main stem bronchus, if it's fortunate, maybe a sleeve resection is possible. Or if the tumor invades the trachea partly, I've heard of carina reconstruction techniques using open surgery, resecting the lower trachea and the main bronchus, and reconstructing the carina via open surgery and joining them together. So, when Dr. Hua thinks there's no other option, it's advisable to consult a surgeon. So, that is my recommendation. Yes. Thank you. Next, I would like to invite Dr. Nok. I have no questions, but I have a comment regarding silicone stents. Back in 2007, I studied with Dr. Fan in California. When I returned, we proceeded. One person placed them in Australia, and one placed them in Vietnam at KHOA, and we were mentored directly by Professor Hariko. Most cases of bronchotracheal stenosis are caused by intubation or tracheostomy. Therefore, if doctors perform tracheotomies carefully, the need for stents might decrease, because tracheostomy is a factor that causes stenosis. Secondly, if intubation lasts too long, the balloon pressure causes scar tissue stenosis. For those cases, placing the stent is very easy, but it is also easy to dislodge. It is easy to dislodge, and secondly, it causes restenosis. Restenosis due to a tendency for keloid scarring. Therefore, with silicone, it is very easy to remove, dilate, and replace it. However, the most difficult case for stenosis in Vietnam is tuberculous stenosis. Tuberculous stenosis is very hard. Once it becomes sclerotic, it is easy to rupture during dilation because some parts are as tough as tendon. Some parts are very thin, so we try to proceed carefully. I have one case of a patient currently being treated for tuberculosis who has left main bronchus stenosis. So at that time, after 2 months of treatment, the checkup showed the BK was negative, so we proceeded with dilation immediately. Dilation and placement were successful, because if we waited until treatment was finished and the scar became hard, it would be hopeless, and we'd have to rely on surgical intervention. There are many cases where after surgical intervention, cutting and reconnection are done, but restenosis occurs. The stenosis was so severe that the patient couldn't even lift their neck up because it was too short to move. That is a limitation of end-to-end anastomosis when dealing with recurrent scarring. So, our experience was passed down to Dr. Vu to perform, but he was still practicing and ended up breaking his arms and legs and everything. Dr. KHOA was the same. He was almost there, and I was supervising. He was almost doing it, then he went riding his motorbike, broke his arms and legs, and gave up. Usually, that is to the point where I later developed a syndrome similar to tennis elbow. Now, this elbow, whenever I turn it, it hurts. I wonder if Dr. Phan has encountered cases like that? Yes, thank you for sharing your experience, Professor Nok. I see in our auditorium there is someone with a lot of experience in diagnosing and treating lung cancer at various stages. I would like to invite Associate Professor Vu. Yes. Earlier, Dr. Phan mentioned that a ground glass opacity, a nodule over 30 millimeters, would justify intervention. Well, the cases at Bach Mai are also very interesting. We intervene much earlier. Clearly, it is smaller than 30, yet we still intervene. But we also know that after intervention, as Dr. Khan mentioned, those cases are often not invasive adenocarcinoma. So, in those cases, sometimes if we don't operate, they still live. Therefore, I wonder if there is any guideline, any approach, to know which ones we should operate on. Earlier, Dr. Hashimoto mentioned that tumors near the pleura often cause tension, so perhaps we should advise surgery early in those cases. But what other factors should we consider for other scenarios? Thank you. In Japan, we might operate sooner than in the US. And the 30 mm cutoff is from Professor TB's 2017 study, because there's a Korean study that followed about 500 GGO cases. And if we use those two rules, one being the 5 mm solid component and the other 30 mm, we only missed one case that wasn't stage 1. So monitoring those two is the most important thing. But I think in Japan, you usually use 20 mm, right? Because we see a lot of these cases. And I think the solid component is more important than the size. The solid part is what worries us, as it's about to spread elsewhere. Yes, and perhaps some studies on lung cancer screening can explain these issues a bit more. However, a problem with that study is that most of the subjects are non-Asian. Speaking of lung cancer, Asians who don't smoke get it more often, and ground glass nodules are more common in Asians. Just like, I guess, race can change the lung cancer situation a bit, Asians and people on the other side might be a bit different, but unfortunately, there is a lack of evidence in Asia. Yes, in Japan, a lung cancer screening study is underway, but the target audience is not like the US. They chose heavy smokers, so certainly. Early stage cancer like ground glass nodules are not very common there, and it's not Asian either. So, Japan is conducting a new study, not targeting just smokers, but all citizens, and hopefully, that study will provide some answers. Yes, please. Please, Mike. Hello, respected teachers and colleagues, I am Dr. Nguyen T. Fung, an internist from KHOA Hospital. I have a question for Dr. Ngô Gia Khánh. In your presentation, you mentioned assessing the ST before surgery to help the surgeon prognose and resect widely. I understand assessing metastasis through histology at the tumor margin is possible, but how do we do it preoperatively? Do we perform a biopsy outside the tumor? That is my entire question.
Right. Respected teachers and colleagues, regarding GGN, we are currently practicing based on guidelines from international associations. And as Professor Phan Nguyen mentioned, pulmonary nodules are more common in Asia than in Europe and America. Therefore, Japanese studies have produced a great deal of research on pulmonary nodules. In current practice, just as Professor Phan Nguyen said, we tend to operate earlier here compared to studies abroad. Typically, based on current practice and echoing Dr. Vu's question, we rely on 3 criteria. First is initial size, second is the solid component size, and third is progression. First, if the initial total size is over 1.5 centimeters, we lean towards clarifying the diagnosis. And usually, as surgeons, we tend to choose surgical resection based on total size. Second is the solid component size, specifically if the solid component is over 6 millimeters within that nodule. When the solid component, the solid part, reaches 6 millimeters, we intervene, or if a solid component appears within a ground glass nodule. So, for a solid nodule under follow-up, if a solid component appears within it, that morphological change is a significant sign, and global guidelines recommend the same. In reality, as mentioned yesterday during the lung nodule presentation, some lesions, like ICE, atypical adenomatous hyperplasia, or GGOs, characteristic of lipidic patterns, can be monitored for 5 or even 10 years without issues, requiring no surgery or intervention, remaining stable. However, the literature suggests there is no clear benefit to extending follow-up indefinitely, meaning it persists until ICE eventually transitions to T1MI. And waiting is just waiting for that exact moment. Why wait for it to become invasive before operating, rather than intervening early if it persists after 3, 6 months, or even 1 to 2 years of monitoring? Regarding the STAS question from Dr. Fung, this is actually new and hasn't been fully incorporated into guidelines yet, appearing only as a prognostic factor in TNM9. Prognosis-wise, most studies are currently limited to evaluating prognosis. This does, however, offer a suggestion for surgical clinical practice. That is, if STAS is present, you should perform a wider resection, because STAS indicates a metastatic pattern, and once metastasis has occurred, the subsequent prognosis is worse. However, as Dr. Fung correctly noted, without a preoperative biopsy, you cannot identify that. So now, it's just a matter of pathology potentially catching up with us later. Typically, during surgery, if cancer is suspected, we perform what is called a frozen section biopsy. So, if we have immediate specimens, with unfixed specimens, and the pathologists can read the STAS status for us right away, we can change our surgical strategy right during the operation. If we do a biopsy, and in about 30 to 45 minutes they report it as STAS positive, we can switch from a segmentectomy to a lobectomy, which is future practice. Right now, even in TNM, it is only studied on post-operative specimens and they introduce it as a prognostic factor. They suggest that in this case, the surgery should be a wider resection, but in reality, we still cannot do that immediate intraoperative biopsy to assess for the presence of STAS. So we still stop there and hope that in the future, we can do that, and then we can change the surgical indications.
Yes. I don't know, time is running out. Let's take one more question from a female colleague. Yes. I'd like to introduce myself. I am Dr. Han from Hanoi Medical University Hospital, specializing in respiratory medicine. I have a question for Dr. Masa Hashimoto and Dr. Khan. In Dr. Khan's clinical case, there was a case of lung cancer with nodes that were FDG avid on PET scan, but upon surgery, the nodes were normal, not metastatic nodes. So, for cases of lung cancer with mediastinal nodes, should all such cases undergo TBNA? Or, what node size requires TBNA? The second question is, if the node is FDG avid, what SUV value requires TBNA, or in which cases is TBNA not necessary? Thank you. Regarding comparing SUV, I don't have relevant information, but I can say that although sarcoidosis or even old tuberculosis is also FDG avid, inaudible, may also be present. And so, yes, I personally feel that FDG should not be used as a reference, although according to guidelines, if you do TBNA after FDG PET, the surgical plan will change by 10 to 20%. Level N2 will be N2B for example, or vice versa for fixed ones. Many of you already know this. So, yes, some centers in Japan is the country that does this type of TV the most, and among them, some now focus on tumors, for example, making system biopsy mandatory for everyone, and it's TP, so it only needs to be 30 or something, and they try staging even if it's only 3 millimeters, they scan everything. Yeah, there's not that much work to do. And according to the Japanese guidelines are a bit different from the American ones, because in Vietnam we have. So it might be easier to do, they are sure that the indications for TBN when questioning the machine have different indications than the world guidelines. I haven't read the details recently, I just encountered that issue and just translated everything into Vietnamese, so I'll send it later. Japan should say how it should be, and how it's not necessary, for example. Yes. Then, the vendor of the phase is because the IBAN, we can't possibly do it for everyone. Then there are 3 important things. If the T is over 30, then maybe N1, N2 could be cancer. If the SUV max of the T is very high, of the cancer is very high, then maybe we have cancer in N1 and N2. The third important thing is if the PET scan has a node, N1. That is hot. If it's hot, the N3 might be normal, so follow those 3. As for the surgical practice perspective, actually, there are 2 cases that Dr. Khan just reported, which are 2 cases among many where nodes on PET, on CT, were suspected positive, but surgically removed and were negative. So that's how we see the difference between node assessment compared to international guidelines when applied to practice in our country. So, in practice, in those cases, regarding live staging, this is actually, well, I don't know about other places, but at Bach Mai, we have been doing this pre-staging for a long time. What does that mean? It means that for N2 cases, even N2B, if we have the capability to approach and achieve an R0 resection, we still operate. It's not like we just do T4N0, but in reports, we actually do it easily. What does that mean? There are 2 possibilities. 1, if there are lymph nodes but we anticipate surgical removal is possible, even 2 or 3 groups. Well, 2 or 3 is a bit difficult, but usually 2 groups, for example, if we can remove group 2 nodes or nodes around the mediastinum, our team still proceeds with the surgery, Professor. And in many such cases, it is true that the patient has no lymph node metastasis at all. And another option, if there are many suspicious nodes, we have methods to biopsy them first, as Professor Pham Nguyen said, not always using PET cord. So there are two techniques we still use, mediastinoscopy, or in cases with contralateral mediastinal nodes and the patient is in very good condition with no significant surgical risk factors, we explain and counsel the family, and if they agree, we perform a preceding surgery, a thoracoscopy on the opposite side to biopsy the nodes there. If the nodes are negative, we then return to operate on the primary tumor on this side, or in many cases with group 2 nodes, group B, or carina nodes, we do a mediastinoscopy first through the neck to biopsy the nodes. Then, if negative, we return for the second stage, which is the radical pulmonary resection. And there are cases where the lymph node biopsy is indeed negative, and many cases where we go back and operate to remove part of the lung and biopsy the lymph nodes as routine. And of course, there are also cases where the surgery confirms it has indeed metastasized, so we stop there and intervene no further. Then, we have run out of time. Also, in Vietnam, many people cook with coal, many people. Regarding old tuberculosis, often when we see nodes on both sides, just like the phrase on both sides, it is usually not cancer. When we see it like that on both sides, because of cooking with coal or old tuberculosis, when we see that, we usually do not see cancer in the nodes. Yes, perhaps we do not have much time. I think there are still very many questions. However, it is time to conclude. I also have a question just a short question, for Professor Pham Nguyen regarding the issue that we clearly see that bronchoscopic biopsy of lung lesions has many advantages over transthoracic biopsy. So, according to current NCCN and STS guidelines, for lung lesions, if the diameter is less than 1 centimeter, we cannot perform a transthoracic biopsy. So, with bronchoscopic biopsy supported by EBUS, I wonder what size lesion we can biopsy. Because we all know that assessing the pathology of lung lesions is extremely important in choosing the treatment method, especially for early-stage lung cancer cases. I would like to hear from Professor Pham Nguyen and then from Hashimoto Fan. Do you agree that under 1 centimeter, we may not need to worry yet? Because we might be biopsying too early. Well, from 1.5 to 2, there are a few cases where I feel we could be right 75 to 80% if we have EBUS. If we have CT from 1 to 1.5, it is still very difficult. In the US, they are starting to do that because they have many robots. They say okay, let's try and maybe we don't need a biopsy yet. But in the US, because if you are wealthy and want to know, they can do it and I think we can wait for a while first. As for bronchoscopy, I really like biopsies. You say bronchial, even if it is 5 millimeters, if it is a bronchial biopsy in the CT, just try it. And according to my experience recently, the technique is advancing more and more, and at 5 millimeters, if it's a 5 millimeters nodule, the diagnostic rate is almost certain. So if the main subject now has a tumor in the lung and there is another nodule and we don't know what it is, if it's for surgery, for example, then operate on the large spot, but just monitoring is also fine. But if it's for a biopsy, then yes, if a biopsy is possible, that's good, but if a biopsy is really hard, then you might be fine for a while. Well, thank you very much to the speakers. So perhaps with this session, before we conclude, I also have a few short takeaways to summarize. For lesions in the lung, the issue of diagnosing the nature of the lesions in the lung is extremely important, especially for early-stage lung cancer. And for early-stage lung cancer, we also know that the AJCC9 classification provides a different direction for treatment. A moment ago, we had a few questions regarding the treatment of early-stage lung cancer, whether to use surgery or to treat by ablation, meaning burning the tumors. So up to the present moment, surgery is still the #1 choice for early-stage lung cancer. Surgery is now trending toward being less invasive with minimal resection. For stage 1A1 lung cancer, meaning tumors smaller than 1 centimeter, the preference is segmentectomy, performed either via VATS, thoracoscopic surgery, or the newer trend, robot-assisted surgery. Robot-assisted surgery is currently on a very steep rise, especially in the US. I know the trend is also beginning to rise in Japan. Currently, for stage 1A1 lung cancer, the rate of using robotic surgery in the US is about 30%. Therefore, it holds the highest percentage in treatment. Regarding the treatment outcomes of robotic surgery, 3 CT reports concluded that robotic segmentectomy yields better results than lobectomy. Only in cases where surgery is not possible. Note that these are cases where the patient cannot undergo surgery due to cardiovascular or respiratory reasons. If the patient's respiratory function is poor, or the surgical risk due to cardiovascular issues is high, then we would choose ablation for early stage cases. Regarding ablation, right now, only RFA has sufficient data to show good results for the early stage. So that is the part we need to take note of. The second issue is for cases of tracheobronchial stenosis. We also see that according to the WAB guidelines for 2024, surgery is still preferred. As for how long of a stenotic bronchus can be resected, I have personally resected a bronchus up to 6 centimeters. However, for 6 centimeters, that is a case where we would have to perform an open thoracotomy and mobilize the main bronchus very, very high up. And as Professor Nock said, afterward, the patient cannot lift their neck up, meaning they are bowing their head all day long. Usually, according to the guidelines, if the tracheal segment is shorter than 2 centimeters, surgical resection is perfectly fine. And when we cut and reconnect, it will yield the best results. In cases where surgery is not possible, the second option is to intervene, either by ablation or by placing a stent. So that is for cases of tracheal stenosis or scarring. As for Vietnam, there is an issue where lymph nodes are very common in our population. I conducted a study on lung cancer treated with surgery. After we biopsied the removed nodes, 51% of the cases with a short axis over 1 centimeter, which guidelines define as metastatic nodes, were actually inflammatory nodes. Therefore, in lung cancer surgery, removing nodes for pathological examination is extremely important. We need staging after surgery to determine the follow-up treatment strategy. In lung cancer, as we know, treatment is multimodal, and the roles of diagnosing genetic mutations and immunotherapy are crucial for better treatment outcomes. We all know the landmark studies on early-stage lung cancer, such as the ADAURA trial, which shows value for lung cancer from stage 1B onwards, while stage 1A is currently under research with no conclusion yet. So those are a few points I wanted to summarize in today's session. Once again, on behalf of the organizing committee, I would like to thank the speakers for their very high-quality presentations. We had a very lively discussion session with many points clarified. And for lung lesions, the first people to detect them are the respiratory physicians. So once detected, the patients are referred to endoscopy and surgical specialists so we can better treat them. Thank you once again to the presenters. Thank you to the teachers and delegates for attending this session, and we would like to conclude this session here to yield the hall for the next one. Thank you.